Okay. Good morning, everyone. Today I am presenting the topic Role of Reproductive Hormone in Decrocystorhinostomy. Coming to the introduction, chronic decrocystitis is a long-lasting, non-infectious inflammation of the lacrimal sac, more commonly seen in middle-aged or older women. The perimenopausal age is the most common age group. This led to the assumption that whether the change in the reproductive hormone play any role in the occurrence of the disease or not. Baber et al. Found estrogen receptor positivity between the premenopausal and the postmenopausal female group. The study was performed to assess the association of reproductive hormone level before and after DCR surgery and to identify if they have any role in the occurrence of the disease. Coming to the methodology, it is a hospital-based observational study. 100 cases were undergone external decrocystorhinostomy surgery. In this our study, blood samples were collected in the red vacutainers and was sent for serum follicle stimulating hormone, serum luteinizing hormone, serum progesterone, and serum estrogen in the Department of Biochemistry under CLI technique assay in Advia Century machine over a period of 6 months. The inclusion criteria was more than 30 years of age and less than 75 years of age were included. Both male and female were included, and patients who give consent to be a part of study. Exclusion criteria was patient with pre-existing hormone level abnormality and who are already on some kind of hormone therapy. Results, out of 100, females were 62 and males were 38, showing a predominance in female group. Coming to the result with association of DCR with serum estrogen level, what we can see that the mean age in male was 53 and female was 38.5 with a t-value of more than 3.2 in female, which show that after the surgery, the estrogen levels were significantly found to be increased in females. Progesterone was non-significant in this association as well as LH. There was significance in the serum FSH level in female. After the surgery, 2.93 t-value was seen in female. That is, after surgery, FSH value was decreased. Studies show that serum estrogen level have a significant association with DCR value is 3.20 at a p-value of 0.05, and FSH was also found to have significant association. Decrocystitis is an inflammation of lacrimal sac which usually occur because of nasolacrimal duct obstruction. Chronic decrocystitis is commonly attributed to the effects of stricture of the nasolacrimal duct arising from chronic inflammation. Baber's et al. Study reveals estrogen receptor positivity in only premenopausal females but no association with other receptors. After extensive literature research, no publication regarding the effect of reproductive hormone on pathogenesis of decrocystitis or regarding the outcome of external DCR was found. My primary focus of the study is to evaluate the failure rate of DCR in patients with increased estrogen level post-surgery and that we can suppress estrogen production by conservative management to decrease failure rate in these patients. These are my references and acknowledgement. Thank you.
Thank you, Dr. Akansha. Do you have any questions? I have a lot of questions actually.
Yes, even I have a lot of questions.
Yeah.
So start, please.
So, can we go back to your first slide? If you have, do we have time?
We have also.
The first slide, the patients that you included in the study.
FCM.
Yeah.
But you can't go back. Okay. So, how many of your patients were in menopause? What was the total number, and what was the number of patients who were in menopause?
So, in my study, most of the patients were in premenopausal group. Premenopausal.
Was there a relationship between your sampling and their menstrual cycle?
Yeah, I was considered the menstrual cycle into association since estrogen level is most commonly overall increase in the follicular phase. But the patients are from the rural area, so that's why they were not giving the proper history. They were saying they were not in the menstrual, they were before the ovulatory phase they were coming to us. And what I seen after I have taken the sample just a day before the surgery and just a day after the surgery. What I have seen is just a day before the surgery, the estrogen level was less than 11.08 picogram per ml. And just after day 1 of the surgery, it was 40 to 50. If we consider the follicular phase also, then there should not be so much of discrimination because of surgery.
Is there a stress response to surgery?
Yeah, estrogen level can increase because of stress, but
would we conclude that DCR increases estrogen level in women, or is it a response to the surgery itself, or any surgery? I mean, we have a lot of interesting questions on this subject.
No, actually what I want to know is that what is the role of DCR in level of estrogen? मतलब estrogen cannot, DCR surgery cannot change the estrogen level.
Yeah, ma'am.
मतलब it would be doing better if you had seen in normal patients who have estrogen level and the patients who are having chronic DACRYOCY status. But surgery itself has no role on the level of estrogen. And secondly, why males are included in the study? That also I don't understand.
Ma'am, men sir, overall included the patient who had undergone the DCR surgery. Then after the surgery, I seen that females are most commonly coming with increased estrogen levels. Male, it was normal because they don't.
No. I mean, this is a line of investigation that is worth pursuing. Since you brought out something so interesting.
Actually, Dr. Javed Ali's one paper is issued. It showed the nasal cycle increasing in menstruals when there is female undergone menstrual cycle. Nasal cycle also changes because of increased estrogen level. Like during the menses, nasal congestions is seen. But I try to exclude this during the criteria so that my estrogen level post surgery does not come out.
Actually, there's a very valid point that the level of the female reproductive hormones could play a role in the etiopathogenesis of LLD obstruction. That is accepted, and it's a very interesting line of investigation because we know that the number of females presenting with acrocystitis and LLD obstruction are much more higher than males. So we want to know why female preponderance is there, whether the role of menopause, post-menopause, the sudden decrease in estrogen level could cause involutional changes either in the bone or in the mucosa, causing the increased preponderance in females. So that is the line of thinking where a lot of research is going on. But what is the purpose of your study in comparing the level of estrogen before and after DCR? That is 1 week before DCR or 1 week after DCR. Suppose the patient is having a period, obviously the estrogen level will be different before the DCR and after DCR it will be different only. What is the connection between the DCR surgery and estrogen level?
So, what I have seen in 100 cases, 18 cases were of failed DCR surgeries. And the failed DCR ones have a higher level of serum estrogen. Then compared to the normal DCR which are fine, doing fine, nothing complication. So, I am saying if we can reduce the estrogen level pre-surgeries, so we can decrease the failure rate in DCR. This is
That's a very far-fetched thing because there is no way that the estrogen level is going to play a role. See, your osteum might be small or the mucosal flap anastomosis might be faulty, and so 101 reasons why the surgery might fail. So to decrease the estrogen level in a female patient, saying that's going to increase your success rate is very, very far-fetched. See, most of the studies going on is whether estrogen level has a role to play in the etiopathogenesis of LLD obstruction. That's the direction in which the research is progressing. They're not saying the surgery fails because the estrogen level is high. The surgery, there's no way, osteum is so big, and there's no way a change in estrogen level is going to shrink your osteum or cause so much mucosal involvement that the mucosa is going to stick to each other, so that you decrease the estrogen level and keep the osteum patent. That's not the way I think anybody thinks. Okay. So anyway, it's a novel way of thinking what you've done, but see, including males in your study, and I think you should have clarity first on what is the purpose of the study, what is the inclusion criteria, and what you're aiming to see. All that you should be very clear. If you say I'm going to measure estrogen levels, then you should not include males, obviously. You can't include the 30-40% of your study male patients and say that the estrogen level didn't fluctuate in males. Obviously it not fluctuate because the estrogen level is, the male patient is not going to fluctuate. So that you have to be clear.
We were actually wondering if postmenopausal women, if we could do DCR universally, whether we could improve their osteoporosis. I mean, that is what we were drawing from after reading your abstract. Very interesting conclusions that one can draw from here, but putting two different lines of thought and trying to draw a conclusion between them where there may not be any biological plausibility is a difficult way to take science forward. Okay.
So what you can do next is that you can plan a study where you can plan patients with these female patients with this DACRYOCY without DACRYOCY and compare them both.
Or you can take pre and postmenopausal women and see whether there's any change.
Okay.
And other surgeries.